Hello everybody, this is Dr. Suchard, and today we're going to be discussing acetaminophen toxicity, which corresponds with Chapter 33 in Goldfrank's Toxicologic Emergencies. The learning objectives for this topic are that when you finish studying the related materials, you should be able to explain why, from an epidemiologic perspective, it's important you have a thorough understanding of acetaminophen toxicity, outline the molecular and cellular mechanisms of acetaminophen toxicity, and be able to correctly utilize the Rumack-Matthew nomogram to determine which patients with acetaminophen overdose need treatment. And while this video will start the discussion of how acetaminophen toxicity is treated, primarily with N-acetylcysteine, there's going to be a separate video that focuses on how that antidote works and on dosing regimens. I want to start off with this fantastic piece of art called Numbskull, created by an artist named Mark Kilner in 2007. And he notes that it was made from a plastic skull, a few pots of superglue, and 630 tablets of paracetamol, which is what they call acetaminophen in the United Kingdom and several other countries around the world. As you know, acetaminophen is a commonly used and effective analgesic, a pain medication, and antipyretic, fever reducer. Here is acetaminophen's chemical structure. The chemical name is N-acetyl-para-aminophenol, which is commonly abbreviated to APAP because it's a lot faster to write. N-acetyl refers to there being an acetyl group attached to the nitrogen of the amino group, and that amino group is on the opposite side of the benzene ring, or in the para position, with respect to the hydroxyl group that makes the aromatic portion of this compound of phenol. If you take a portion of the full chemical name, you can see where we get the generic name acetaminophen. Now here's something really cool. If you look at the letters that are left over, when you remove acetaminophen, that gives us the brand name Tylenol. And here's where we get paracetamol, which is a more chemically descriptive generic name. Also, we need to recognize that whatever name we use, acetaminophen is the #1 single cause of acute liver failure in the US and several other Western countries. In the United States, acetaminophen is responsible for the largest number of poisoning fatalities reported to poison control centers, and about half of all cases of liver failure in adults. The table at the top of this slide is from the 2021 report of the National Poison Data System, showing that acetaminophen was involved in nearly 9% of all reported poisoning deaths and nearly 20% of all deaths involving only a single substance. Here's more tabular data from the 2021 National Poison Data Systems report. There are more than 100,000 acetaminophen exposures reported to poison control centers in the U.S. annually, resulting in more than 30,000 being evaluated in healthcare facilities. And many of these patients seen in healthcare facilities are treated with N-acetylcysteine, often abbreviated to NAC. In fact, when you look at all the different therapies used to treat all poison patients, the number of uses of NAC, over 30,000 times per year that we know of, is only exceeded by the use of antiemetics, benzodiazepines, IV fluids, opioid analgesics, and oxygen. And all of those are pretty non-specific supportive care measures, making N-acetylcysteine arguably the most important antidote you'll need to know just from how commonly it's used. Now, therapeutic acetaminophen dosing is remarkably safe and effective. Think about how many doses are given every day without any adverse effects or toxicity. The large numbers of reported exposures, liver injuries, and antidote use are really only indirect markers of how ubiquitous acetaminophen is. It's found in every healthcare facility, nearly every home, and you can purchase jugs filled with multiple LD50 doses over the counter without anyone blinking an eye. Acetaminophen is safe when used correctly, so let's focus on the other side now. How does acetaminophen toxicity occur? From the toxicologist's point of view, the main purpose of the liver is to increase the water solubility of xenobiotics, making them easier to eliminate, either through the kidneys and into the urine, or through the bile and then into the GI lumen and out with the feces. The liver does this through two main kinds of reactions, phase 1 and phase 2 reactions. The phase 1 reactions either insert or unmask polar functional groups, which helps to increase the water solubility of the substance. Many of these phase 1 reactions are oxidation reactions where we can add oxygen-containing polar functional groups, and these reactions are catalyzed by cytochrome P450 enzymes. After that, we have the phase 2 reactions, which covalently add a bulky water-soluble group to the polar functional groups that were created in the phase 1 reactions, further increasing the water solubility. and the water-soluble molecules that get added on are very typically glucuronide, sulfate, or acetyl groups. If you take a look back at the structure of acetaminophen, you see that it already has several polar functional groups on it, so it doesn't really need to undergo phase 1 reactions. In fact, most of the acetaminophen gets metabolized by glucuronidation or sulfation, although some small percent can be directly eliminated in the urine unmetabolized, and everything is good so far. However, a small amount, about 1 to 5% of the acetaminophen, does get oxidized in a phase 1 reaction, forming a reactive metabolite called N-acetyl parabenzoquinone imine, or NAPQ. This reaction is catalyzed primarily by the cytochrome P450 2E1 isozyme. If you take a look at NAPQ's chemical structure, you see that there has been some movement of the double bonds around what used to be a benzene ring. That particular arrangement makes it a quinone, which is desperate to rip an electron off a nearby molecule so that the double bonds can get back to the more stable aromatic benzene ring structure. This makes NAPQ a strong oxidizer. Removing electrons oxidizes and adding electrons reduces. Living beings are constantly under oxidant stress as a baseline. Indeed, we live in this sea of 21% oxygen, so we'd better have a way of dealing with such oxidant stress, and we do. Glutathione is an endogenous reducing agent that can take care of NAPQ and other oxidants. Glutathione is a small protein molecule composed of 3 amino acids, one of which is cysteine, so there's a sulfhydryl or SH side group, which will easily give up electrons from the SH bond. The sulfhydryl group here is so important that the abbreviation for glutathione is just GSH. Basically, if there's an oxidant stress and something wants to rip electrons off of nearby molecules, glutathione offers itself up as a sacrifice. Take my electron, please. Later, when the oxidant stress is gone, the oxidized glutathione gets reduced back again. So, when NAPQ is created during acetaminophen metabolism, there's some glutathione around, and when glutathione reduces the NAPQ, it becomes covalently bound or conjugated to it in the ortho position. And in the process, the double bonds of the quinone get rearranged to reestablish an aromatic benzene ring. In fact, what we've got now is a molecule of acetaminophen covalently bound to glutathione, a bulky water-soluble group, allowing for better renal excretion, and everything is still good. We've got plenty of glutathione for the amount of NAPQ produced after therapeutic dosing. But where we get into trouble is when the glutathione stores are depleted, as with an acetaminophen overdose, resulting in excess NAPQ production. When glutathione stores are reduced to below 30% of normal, that's when we start seeing oxidant injury to the cells. Since most of the cytochrome P450 metabolism occurs in the liver, most of the NAPQ is produced in the liver, and therefore most of the injury occurs in the liver with acetaminophen toxicity. And now here's a throwback to histology and the structure of the liver lobule. Most of the cytochrome P450 is found in the centrilobular area, and because NAPQ reacts so quickly, it will cause most of the injury right where it's produced, resulting in a pattern of centrilobular hepatic necrosis. Clinically, acetaminophen toxicity can be divided into 4 stages. Stage 1 occurs right after ingestion. In this stage, hepatic toxicity has not yet occurred because it takes time for APAP to be metabolized into NAPQ. If you check liver labs, they'll be normal. Many patients are completely asymptomatic in stage 1, and you wouldn't suspect anything unless they told you they had overdosed or you happened to order a serum acetaminophen level. Some patients in stage 1 can have nausea, vomiting, and malaise, but phase 1 is typically rather benign, and many patients never progress beyond this stage and will recover without incident. Now, there is a possible exception in patients with a massive acetaminophen overdose of many grams. These patients can present shortly after ingestion with an altered level of consciousness and severe metabolic acidosis. We're going to cover this atypical presentation in a separate video since it brings up the topic of potentially using fomepizole as an antidote for acetaminophen toxicity, which is a recent development since the 2010s. With stage 2, we see the onset of hepatic injury. As just mentioned, many patients never even progress to this stage, but if they do, we will begin to see elevations in the hepatic transaminase levels, with a rise in the AST starting within 12 to 36 hours post-ingestion. The ALT starts to rise shortly thereafter, and we see the rise in AST and ALT levels are virtually equal. Other signs of liver injury will include an increase in the prothrombin time, international normalized ratio, and the bilirubin level. So we can start to see these laboratory signs of liver injury, but the symptoms experienced by the patient are variable in stage 2. In some patients, they may have been symptomatic with nausea and vomiting initially in stage 1, but are now feeling okay, even though the acetaminophen is beginning to exert toxic effects. Stage 3 is when we will see maximal hepatic toxicity within 72 to 96 hours after ingestion. Patients may progress to fulminant hepatic failure, and even if they don't, it's possible to have hepatic transaminases reaching very high levels of 10,000 or more. Renal failure can also occur and is associated with worse liver injury. If a patient progresses and dies, this typically happens 3 to 5 days after the acetaminophen overdose. It's quite possible a patient's hepatotoxicity will plateau and they will go on to recover. Stage 4 is the resolution stage. Most lab abnormalities will resolve within a week, although the abnormal labs from kidney failure can take longer. And this resolution or recovery, for those patients who don't go on to die of liver failure, is complete. These patients will regain their previous liver function. They are not now sensitive to acetaminophen and can use therapeutic doses in the future without additional risk. Since the toxicity from acetaminophen overdose is delayed, APAP has to be metabolized into NAPQI, it would be very helpful if we could predict who might go on to develop hepatotoxicity before it happens. So in the 1970s, the Rumack-Matthew nomogram was developed, and we're going to be spending some time on this because it's important to use and to interpret correctly. On the left-hand side here, we see the nomogram, and the point is to plot that patient's serum acetaminophen level on the y-axis versus how many hours it's been since the patient overdosed on the x-axis. There are 2 parallel diagonal lines on the nomogram. The upper line is labeled here as the Rumack-Matthew line, and that's what was published in Pediatrics in 1975. What Rumack and Matthew did was to plot the points from acetaminophen overdose patients on a graph like this to see if it was possible to determine some threshold line below which a patient would be at very low risk for developing hepatotoxicity, and therefore may not need treatment or admission to the hospital. So they had to define what they meant by hepatotoxicity, and this was defined as the patient developing an AST level of over 1,000 following acetaminophen overdose. Every patient who went on to develop fatal liver injury fits this definition. But what about the patient, say, whose AST maxed out at 900? That patient could be pretty sick clinically and will probably benefit from being admitted, but they wouldn't meet the definition for hepatotoxicity despite clearly having some liver injury. But they had to recover since we know that their AST never got any higher. Anyway, they plotted these acetaminophen versus time since exposure points on a graph and found that virtually all the points fell above this Rumack-Matthew line they were able to plot. Therefore, any new patient falling above this line should be admitted, while those below the line should be safe from dying from hepatotoxicity. The line that they drew starts on the left-hand side at a serum acetaminophen level of 200 micrograms per milliliter 4 hours after exposure. Looking closer, you can see that the y-axis is logarithmic, making this a semi-log plot. And we know that a decreasing line on a semi-log plot represents first-order drug elimination. The slope of this line corresponds to a half-life for acetaminophen of 4 hours, which is close to what's seen in reality. If the threshold danger level for acetaminophen 4 hours after ingestion is 200 micrograms per milliliter, then it would be 100 micrograms per milliliter 8 hours after ingestion, and so on. When the FDA evaluated this data to determine indications for treating acetaminophen overdose with N-acetylcysteine, they inserted an extra safety factor and lowered this line by 25% at all points to create the so-called treatment line. Thus, the treatment line indicates that any acetaminophen level of 150 or above at 4 hours after ingestion is an indication for treatment. In the United States, we typically use the 150 treatment line, even though it's not the line based on the actual data, which could be overly sensitive and not as specific. But in some places, they use the original 200 line, unless there are some factors believed to put the patient at higher than usual risk. This slide is just a fun little detour. There's a connection here with the 1980 comedy movie Airplane. One of the supporting characters, played by actor Leslie Nielsen, is named Dr. Barry Rumack, who is named after the same Dr. Rumack from the Rumack-Matthew nomogram because he was a neighbor to the Zucker brothers who wrote and directed the movie. And now I'm going to show you a very brief clip from the movie with what is perhaps Dr. Rumack's most famous line.
The stewardess said, both pilots.
Can you fly this plane and land it?
Surely you can't be serious.
I am serious. And don't call me Shirley.
Now we're going to practice using the Rumack-Matthew nomogram to help risk stratify some theoretical acetaminophen overdose patients. Assume that a patient had an APAP level of 35 micrograms per mil 10 hours after an overdose. Here's where 35 micrograms per mil falls on the y-axis, and here's 10 hours on the x-axis. So when we plot the point, it falls below the 150 treatment line, so we wouldn't need to start antidotal therapy and may not need to admit the patient to the hospital for medical as opposed to psychiatric reasons. This time, we measured an APAP level of 175 micrograms per mil 4 hours after ingestion. Here's a level of 175, and here's 4 hours after ingestion. So when we plot the point, it falls above the treatment line, and we'd start antidotal therapy, admit the patient, or at least have prolonged observation in the emergency department, and consult psychiatry if the ingestion had a suicidal intent. When used properly, the Rumack-Matthew nomogram is easy, but there are multiple potentially complicating scenarios when applying it. Note that the nomogram is only good for acute ingestions occurring between 4 and 24 hours previously. You can't plot a point on this graph earlier than 4 hours after acute ingestion because the lines don't extend in that direction. While this issue has been studied by several groups, there's no consensus about what to do with APAP levels that are drawn too early. However, a patient with an undetectable APAP level before the 4-hour mark, for whom there's no historical reason to suspect acetaminophen ingestion, probably doesn't need a repeat level at 4 hours. Also, this nomogram can't reliably be used for cases of chronic overingestion, staggered or repeated ingestions, or ingestions occurring more than a day earlier. And it's kind of obvious that you can't plot a point if you have no idea of the time of ingestion. However, if you have a range of time in which the ingestion must have occurred, you could just assume that the ingestion occurred at the beginning of that period in order to make the assessment that maximizes patient safety. In some scenarios, there is a concern that a patient could have an initial APAP level below the treatment line, but if you checked it again later, it might be above the treatment line. For instance, there are extended-release Tylenol formulations where each tablet is composed of a slow-releasing core surrounded by regular Tylenol. The idea being that it's like taking one Tylenol now and another one a few hours later. Also, if a patient co-ingested a drug that slowed GI motility, such as opioids or anticholinergic agents, that might delay the absorption of acetaminophen since it'll hang out longer in the stomach before moving on to the small intestine where it's absorbed better. Theoretically, these situations all could increase the risk of crossing the treatment line late. However, there's no good evidence that these actually increase the risk of hepatotoxicity. Indeed, patients with co-ingestions were not excluded from the early studies used to create the treatment lines, and no one was checking to see if there were late line crossers or not, so this theoretic risk was probably already accounted for, and we shouldn't change our practice based on these concerns. Another potential error in applying the Rumack-Matthew nomogram that I've seen that sometimes occurs is just the opposite, where the patient initially has a point above the treatment line, but a repeat APAP level is obtained which is now below the line. This is a misapplication of the nomogram since it was never intended to be used to determine when to stop treatment. It was only intended to determine when to start treatment. We expect the APAP level to go down as time progresses, and if the half-life in a given patient is sufficiently shorter than 4 hours, you'll expect that a later point will plot below the treatment line. But the studies that define the nomogram never considered repeating APAP levels to discontinue therapy, so there's no evidence that doing this would be safe. Since APAP toxicity occurs from cytochrome P450-mediated metabolism, theoretically anything that induces these enzymes, such as chronic alcohol use, could also increase risk, since more NAPG can be produced. Many studies have looked at this question, and some clinicians and treatment guidelines take it into consideration. But the evidence that alcoholism increases risk of acetaminophen hepatotoxicity is poor, and it's particularly weak if we consider normal therapeutic APAP dosing. Nevertheless, the FDA requires a warning label on over-the-counter APAP-containing products, warning the consumers of danger if they have 3 or more alcoholic drinks per day. As already mentioned a few times, the standard treatment, the antidote as it were, for acetaminophen overdose is N-acetylcysteine. This is a molecule where an acetyl group is connected to the N, or the amino group of cysteine, an amino acid, thus N-acetylcysteine, or NAC. N-acetylcysteine works to treat or to prevent acetaminophen hepatotoxicity by repleting glutathione. As shown here, it's only a few metabolic steps to convert NAC into glutathione. More details about NAC's mechanism of action and how it's dosed will be in a separate video. But we've already seen that NAC can be given either enterally or intravenously, and both methods are very effective. The FDA-approved enteral dosing protocol was approved in 1985 and lasts 72 hours, while the FDA-approved IV dosing protocol was approved in 2004 and will take 21 hours. Again, we'll discuss more details in a separate video focusing specifically on NAC as an antidote. Acetaminophen overdose patients have a limited number of potential outcomes. Either they do well and fully recover, and this is the great majority of patients admitted for treatment, or they do poorly. And doing poorly here means progressive liver injury, fulminant hepatic failure, multisystem organ failure, and death, typically within 3 to 5 days of ingestion. But there is the possibility of liver transplantation if it can be arranged in the limited amount of time available. The most well-recognized set of criteria detailing who is a candidate for liver transplantation was created by King's College in London, England. The UK has a nationalized health system, and King's College is their major transplant center. So they needed to codify who would get transferred for potential liver transplantation. They needed to find the patient sick enough that transplantation was indicated, but also to not accept patients who had a good chance of recovery without transplantation. The King's College criteria rely on several lab value and clinical features, but what's notably absent are the hepatic transaminase levels. Acetaminophen hepatotoxicity can cause very remarkable elevations in the AST and ALT, sometimes several tens of thousands, but that alone is not an indication for a transplant. Per the King's College criteria, a patient should be sent to a transplant center if they are acidotic, if their pH is 7.3 or lower, or their lactate level is greater than 3 millimoles per liter after adequate fluid resuscitation, or if they have renal failure, coagulopathy, and grade 3 or 4 hepatic encephalopathy. In the US, where we don't have socialized medicine, but we do have a more litigious medical legal situation, we may very well start contacting transplant surgeons and transplant centers if a patient's transaminases are rising into the thousands. But remember that recovery can occur even with otherwise very scary liver enzyme levels, unless the other indicators of organ failure also appear. It's happened before that patients with scary elevations in their transaminases have been transplanted when a consulting toxicologist wouldn't have recommended it. This is obviously a very expensive procedure, and now the patient will be on lifelong immunosuppressing drugs, when simply waiting a bit longer, continuing treatment with NAC, could have resulted in recovery. And that's all for this video about acetaminophen toxicity. There are 2 other related video discussions, one focusing on the use of N-acetylcysteine as an antidote, and the other looking at those acetaminophen overdose patients who acutely develop severe metabolic acidosis and the potential use of fomepizole as an antidote. I'll be seeing you around.